Well, gefitinib is one of the very first drugs we were able to use a randomized comparative study to show the benefit of an oral drug to be better than chemotherapy in the first-line setting. Specifically, has to be on the EGFR mutation positive patient. And it's just more than one study, which was IPAS. There are two additional studies from Japan selecting the patient with the EGFR mutation, randomized to either gefitinib chemotherapy, able to demonstrate a superior effect in terms of response rate and progression-free survival. So that is the major benefit. Now, the oral drug, they give you the so-called convenience of not necessary to receive the intravenous injection. And furthermore, there is less toxicity and better quality of life. In the IPAS study, we have brought extensive study on the quality of life. Now, overall, as a group, gefitinib had actually better quality of life in terms of the FAT-L and also the TOI, the so-called clinical trial index. However, more specifically, in the patient with EGFR mutation, the improvement quality of life is almost double comparing to the chemotherapy alone. So there's no doubt in a prospective randomized study, there is solid evidence that the TKI such as gefitinib is better than chemotherapy. Less than 15 years ago, chemotherapy has always been the standard treatment for patients with advanced stage lung cancer. Now, with such, we have done extensive research with different chemotherapy drugs. However, with John Schiller's paper, we knew that there's a plateau that we have reached. So only with the coming around of the targeting drug, and only with the identification and discovery of the EGFR mutation in 2004, we all of a sudden had a targeted, personalized medicine. Now with this study, we're able to show patients with EGFR mutation had done a lot better with the oral drug. Then the job of the doctor is to identify the patient with this EGFR mutation so that to provide the treatment of choice. Now the problem is the reluctance to change. In order to be able to identify the EGFR mutation, the doctor has to get a bigger biopsy using a crawl needle instead of a fine needle biopsy. We have to send the specimen to the appropriate laboratory, which may or may not exist right next to your door. However, all this effort of being able to identify the patient with mutation, we can offer the treatment. Now, the doctor can also try to say, hey, maybe I can do a second line. Maybe I just do it in the future. But that's not the right thing. The right thing is to offer the patient a choice where the patient can decide for themselves what they want. Now, without the knowledge of the present absent EGFR mutation, the patient had no choice. So stepping into the new era, stepping into the new paradigm, doctor had to work hard. Find the mutation, let the patient make the choices for themselves.